Good morning friends, welcome back to my YouTube channel Medical Classes by Dr. Srinidhi Kumar Acharya. Please don't forget to subscribe to my channel and also please give your valuable comments. You can also visit the playlist. In the playlist I have provided almost all the topics in a very systematic order and I hope this will be very convenient for the continuous study. My dear friends, we have been discussing about leukemia. In the last class we have seen what do you mean by acute and chronic leukemias. It all depends upon the level of the maturity. Proliferation is more and maturity is less. That leads to acute condition. And if this proliferation has been arrested in the earlier stage itself and cells are comparatively more mature, then it leads to chronic presentation. So today we will discuss about leukemia in detail. Leukemias are the most common childhood cancer. That's why we are giving more stress for this. Leukemias are the most common childhood cancers. 1/3 of the pediatric malignancies are due to leukemias. You can estimate the level of the severity. 1/3 of the total pediatric malignancies is due to leukemias. In the leukemias, there are mainly two types. One is lymphoblastic and another one is myeloblastic. And this lymphoblastic and myeloblastic, we know that what do you mean by lymphoblastic from the lymphoid series. Myeloblastic means from the myeloid series. And this lymphoblastic and myeloblastic are again classified into acute and chronic. That means acute lymphoblastic leukemias, chronic lymphoblastic leukemias, acute myeloblastic leukemia and acute chronic myeloblastic leukemias. Now among all these, acute lymphoblastic leukemias is most common variety in the childhood practice. Okay, so 75% of the cases of leukemias are acute lymphoblastic leukemias, and this is of childhood onset most of the time, usually 3 to 5 years or 3 to 6 years. It's the most common age group in which it was found. 75%, and AML, acute myeloblastic leukemia, is at only 20%. Now peak incidence in the children is at the age of the 4 years to 10 years, and it increases slightly during the teenage years. It increases slightly during the teenage years. Whereas the chronic lymphoid leukemias rarely afflicts the children. Chronic lymphoid leukemias, okay, chronic lymphoblastic leukemias very rarely affects the children because it is a disease of the adults. Now, leukemias are again classified by WHO in different methods. Classification of the neoplasm of the leukocytes as per WHO goes lymphoid proliferation. In the lymphoid proliferation, we will have leukemic and lymphoma lymphoid proliferations. Then comes the myeloid proliferation, again in the leukemia and lymphoma. In both the conditions this can happen. And histocytic classification, if you see, proliferation of the macrophages, dendroid cells, etc. So this is the classification of neoplasm of leukocytes, not only leukemia, total leukocytes according to WHO. Now lymphoid neoplasia. Lymphoid neoplasia according to WHO, this is the classification only in the lymphoid series. Lymphoid precursors are of three types, we know that: B cells, T cells and natural killer cells. So accordingly, according to WHO, we will have B cell malignancy, T cell malignancy and natural killer cell malignancy. So this is related to lymphoid tissues, therefore it's called as lymphoid neoplasia. Now coming to the lymphoid neoplasia according to WHO, one more classification is acute precursors B cell leukemia, lymphoma. That means acute precursor B cell leukemia or lymphoma. Also called as large cell leukemia. This is also called as large cell leukemia. So it is again called as pre-cell B acute lymphoblastic lymphoma or leukemias. Okay, precursor cell B acute lymphoblastic leukemias or lymphomas. Similarly, we will have the chronic peripheral B cell leukemias. Chronic peripheral B cell leukemias or lymphomas. It is also called as small cell leukemias. It is also called as small cell leukemias. Similarly, acute precursor T cell leukemias. This is about the B cells. Similarly, acute precursor T cell leukemias or T cell lymphomas. It is also called as larger cell leukemias or larger cell leukemias, and it is also called as precursor cell T acute lymphoblastic leukemia or lymphoma. Similarly, chronic peripheral T cell leukemias or lymphomas. This is also called as small cell T cell leukemia or lymphoma. One more classification in the lymphoid neoplasia is, according to WHO, is Hodgkin's lymphoma. Now, some of the chronic peripheral B cell leukemia, there are many types of them. Chronic peripheral B cell leukemias, we have different types. Hairy cell leukemias, follicular lymphoma, mantle cell lymphoma, Burkitt's lymphoma, marginal zone lymphomas, splenic and nodal marginal cell lymphomas, and many more. There are different types of lymphomas are there. Now we come to the very important and most common type of leukemias in childhood practice, that is acute lymphoblastic leukemias. What is this? ALL. Childhood acute lymphoblastic leukemia was the first form of disseminated cancer which can be curable with the chemotherapy and radiation. This is the best part of this particular leukemia. This is a curable. This is a curable with the chemotherapy and radiation. Okay, the more common in boys rather than girls. Studies suggested the role of certain environmental factors in the formation of ALL. Some studies suggest in utero origin of leukemias between the 5 months to 2 years. That means if the leukemia identified in between 5 months to 2 years, studies suggest that the origin of that particular leukemia has been in utero itself. Now this is more common, ALL is more common in the patients of Down syndrome, Bloom syndrome, and some of the immune deficiency problems. Epstein-Barr virus, name has to be remembered. Epstein-Barr virus is also associated with the development of B cell leukemia. Epstein-Barr virus is quite dangerous, and this is also, it is all associated with many of the disorders, Epstein-Barr virus. Okay, so this is also has got its association with the B cell leukemias. Now, acute lymphocytic leukemias, ALL, is most common in children, most occurs in individuals younger than 15 years. The more common age group is 2 years onwards up to 10 years. Slightly more frequent in boys than girls. Of course, it can be found in the both boys and girls, male and female, but incidence is quite more in boys compared to girls. Now, acute lymphoblastic leukemia or lymphoma are the neoplasm composed of immature B cells or T cells, precursor B cell or precursor B cells, which are referred as lymphoblasts. Now, actually, this is a neoplasm which is composed of a lymphoblast. Lymphoblast is an immature cell. Okay. Now we need to do the DD between myeloblast and lymphoblast. If it is from the myeloid series, then it is called as myeloblast. If it is from the lymphoid series, it is called as lymphoblast. But histologically we can differentiate it. Okay, myeloblast and lymphoblast, and we can come to accurate diagnosis whether it is ALL or AML, because prognosis is quite good in ALL if you give radiotherapy and chemotherapy. Now, myeloblast, the size of the cell is quite larger, whereas in the lymphoblast it is small. Nucleus in the myeloblast it is round and oval, whereas in case of lymphoblast it is round and oval. Yes, same. Nucleoli is only 2 to 5 here, but in lymphoblast it is 1 to 2, still lesser. Nuclear matter, very fine in myeloblast, fairly dense in lymphoblast. Nuclear chromatin, in case of myeloblast it is fine, whereas in case of lymphoblast it is coarse. And in cytoplasm, very important, this is one of very important identification mark, cytoplasm. Cytoplasm in the myeloblast is moderate, whereas cytoplasm in the lymphoblast is scanty. very less. Okay, almost all this is the same thing given in the table. Now this is C. In case of the lymphoblast, the cytoplasm is very scanty. Okay, whereas in case of myeloblast, cytoplasm is moderate. Moderate cytoplasm will be seen, and nucleoli are prominent. See, whereas in case of lymphoblast, above picture, the nuclear chromatins are very coarse and they are not identified. But here, nucleoli etc. is very clearly identified. So cytoplasm and this nucleoli, these are the two important differentiation point between myeloblast and lymphoblast. Talking about incidence of ALL, 85% of the B cell acute leukemias, that is also called as childhood acute leukemias, are ALL, and T cell acute leukemia is less common. Okay, B cell acute leukemia is more common, T cell is less common. T cell acute lymphoma can be manifest in the adolescent male also, but leukemia is most common in childhood. B cell acute leukemia is very common in childhood practice, and incidence is maximum after 2 years, that is after 3 years of age. Whereas T cell acute leukemia peak incidence is at the adolescent age. So in total, acute lymphoblastic leukemia is very common in children. In that also, B cell acute lymphoblastic leukemia is very common. Now this is the classification of acute lymphoblastic leukemia. Classification can be done on two bases. Morphological basis, that is called as FAB classification, done in 1976, and another one is WHO classification. Morphologically, it is classified into three types. Okay, ALL is classified into three types morphologically: L1, L2 and L3. So this depends on morphologically. Okay, classification is morphologically. That means depends on the size. So L1, L2 and L3. L1 means the size is larger, L2 is still larger, and L3 also it is larger. And nucleus and chromatin ratio, that is quite normal in L1, large and heterogeneous in case of L2, and large and homogeneous in case of L3. Cytoplasm is scanty, moderate and basophilic. Vacuolation, that is average and prominent. So nuclear membrane, in L1 it is regular, in L2 it is irregular, and in L3 also it is irregular. Nucleus is invisible in L1, and 1 to 2 prominent nucleus will be seen, or 1 to 2 prominent nucleus will be seen in case of L3. So this is how morphologically we can classify, and this is helpful to implement the treatment, which actually stage is going on, and how much intensively we have to go for chemotherapy and radiotherapy. Classification of acute lymphoblastic leukemia according to WHO method: B lymphoblastic leukemias or lymphomas, which is not otherwise specific; B lymphoblastic leukemia or lymphoma, which is recurrent and genetic abnormalities with the recurrent genetic abnormalities; and T lymphoblastic leukemias or lymphomas. Looking at the pathology of the ALL. In ALL, what is a pathology? The chromosomal aberrations deregulate the expression and function of the transcription factors needed for normal lymphocytic development. The problem, as I told earlier, the genetic problem. The genes which is responsible for carrying out the normal leukocytic proliferation, normal cell division, are malfunctioning or deregulated. And as a result, leukocyte division or proliferation will not follow the normal rule which is accepted by our body. They follow their own rules. Therefore, the cell division become erratic and out of control. So this leads to maturation arrest and induce increased self-renewal differentiation. So what happens is apoptosis is blocked, proliferation is blocked, differentiation is blocked. Apoptosis means a cell death. A programmed cell death is called as apoptosis. A cell has to die after some time. That's called as apoptosis. There are so many factors which is responsible for this. The cell will not die, rather it will go on dividing irregularly. Okay, so proliferation, at one point in time, proliferation has to be stopped. Here, the proliferation will also not stop. It is also continuous. Okay, differentiation has takes place with each cell division. This is also not taking place. So only the proliferation is increased, leading to accumulation of the undifferentiated immature cells. That's the pathology. Clinical features of ALL. Symptoms due to bone marrow depression. There are so many symptoms due to bone marrow depression. So there may be recurrent respiratory tract infection, pallor, fatigue due to anemia, bruising, petechiae due to thrombocytopenia, and persistent fever because of neutropenia. So this is a problem which occurs because of bone marrow depression. Bone marrow is not producing anything now. That means abnormal cells are produced, lymphoblast and myeloblast both. Symptoms due to organ infiltration. Now these blast cell, they now produce in excess amount, they spread from there to the other sides and they start infiltration. They come and occupy other places. Okay, so that leads to bone pain due to bone marrow expansion and subperiosteal infiltration, lymphadenopathy, then arthralgia because of bony infiltration again, splenomegaly and hepatomegaly, and involvement of the CNS, headache, vomiting, etc. start. Even the testes may be affected, GIT may be affected, kidney may be affected. Infiltration. These blast cells are coming and get settled there. Now complications due to compression of the large vessels and airways of the mediation. Sometimes this blast cell is get deposited somewhere. This causes compression over the other organs, including some of the important vessels and also airways in the mediation. That leads to some other breathing problems and all. What is the prognosis of ALL? Factors associated with the favorable prognosis is age between 2 to 10 years, very important one, low white cell count, trisomy chromosomes 4, 7 and 10, presence of translocation of the chromosome 12 and 21, hyperdiploidy. Factors which are associated with the worst prognosis is age less than 2 years, presentation in the adolescents or the adults, and peripheral blood blast is more than 1 lakh. That means if the white cell count is lesser, maybe 40,000, 50,000, good prognosis. If the white cell count is more, that means they are not the normal cells, blast cells, or more than 1 lakh, then it is not a favorable condition. Some of the disease conditions are also favorable. For example, trisomy chromosomes 4, 7 and 10, trisomy is there, then it is quite favorable. Exact reason I don't know. Okay. Now lab diagnosis and blood picture. If you look into the RBC in acute lymphoblastic leukemia, the number is decreased, that is anemia, but normocytic normochromotype will be seen because RBC is not a lab factor. RBC stem cells are normal. The problem is only with the myeloid cell series and as well as lymphoid series. In ALL, it is only the lymphoid series. So TLC, yes, TLC normal to leukocytic range will be there. Monocyte, neutrophils may be normal, but leukocyte count will go into increase. DLC, large number of circulating lymphoblast, more than 20% will be seen. And lymphoblast are round and convoluted nuclei with a high nucleocytoplasm ratio and absence of cytoplasm granularity. Some smear cells in the peripheral blood picture showing the degenerated leukocytes may be also seen in the lab. Lab investigation, bone marrow studies are important. Bone marrow is hypercellular and bone marrow examination shows 20 to 90% of the cells are malignant, undifferentiated, immature cells of the precursor B or T cell origin, that is lymphoblast, and megakaryocytes are usually reduced or absent. Looking into the cytochemistry, this may be used as an adjacent to the Romanowski staining for determining the type of leukemia. Periodic acid SCIF, that is PAS, is positive in mature lymphocyte cells in ALL. Acid phosphatase, focal positivity in leukemia blast cell in ALL. Myeloperoxidase, negative in mature cells in ALL. Sudan black is negative in mature cells in ALL. Non-specific esterase, NSE, is negative in ALL. So these are the other cytochemistry factors which are helpful for the diagnosis. This is the immune phenotypes and immune markers which are commonly used for ALL, CD7, CCP3, CD2, TDT, etc. For the B cell, we have got TDF. What is the treatment now? Generalized and supportive treatment is important. Insertion of the central venous cannula, number 1. Supplementation of the blood products, number 2. Prevention of the further lysis of the cell. These are the 3 important principles. Coming to the specific therapy, if you see, this is given in children and adults. This includes treatment in several phases. First is induction, then consolidation, then maintenance phase. Like this, 3 phases will be there. Induction phase, remission induction. That is, aim of this phase is to kill the tumor cells which are rapidly growing and we have to achieve their remission. Remission of the ALL is less than 5% of the blast in bone marrow, normal peripheral count, and absence of the signs and symptoms of the disease. If there is absence of the signs and symptoms of the disease, if the peripheral count is normal, and if the blast cells are reduced less than 5%, so then we will call it as it is a remission of ALL. Next one is intensification phase. What is the intensification phase or consolidation phase? High dose multi-drug chemotherapy is used to reduce the tumor growth. Okay, so vincristine, cyclophosphamide, mercaptan urine, etc. These are some of the commonly used drugs. Next come to the maintenance phase, last one, that is we have to maintain the things. Chronic lymphocytic leukemia, that is CLL, and that we will discuss in the next class. Thank you very much.